Case history. Mr. R, 40 years old, complains of fever, it's 2 days, and altered sensorium, it's 2 days. History of present.
When somebody comes with a fever and altered sensorium, what are the possibilities that comes to your mind?
Sir, fever and altered sensorium, meningitis.
Yes.
Then thyroid storm.
Okay.
Then
all infections of nervous system, maybe encephalitis, maybe cerebral malaria. Okay, and there are a few other possibilities also. We'll discuss later on. Present illness.
History of presenting illness. Fever, high grade in nature, sudden in onset, associated with altered sensorium. History of abdominal discomfort. Review of symptoms not contributory. And history of drinking heavily till 4 days back, followed by altered behavior and distress.
So somebody is drinking and stopping 4 days back. Now he's coming with fever and altered sensorium. What all things come to your mind?
Sir, it can be hepatic decompensation and hepatic encephalopathy.
It can be, yes. Anything else?
Then
he's stopping alcohol and then
withdrawal, alcohol withdrawal.
So what type of situation is that?
Delirium tremens.
Yes. When does delirium tremens start? How many days after stopping alcohol?
Delirium tremens.
Usually after 3rd day, before the 7th day. So the right time he has come, right? Past history?
Past history, diabetes mellitus, hypertension, heart disease, and thyroid disease. Patient has diabetes mellitus, heart disease, hypertension, heart disease, and thyroid disease.
Okay.
Then
personal history.
Personal history, chronic smoker and chronic alcoholic. Bowel and bladder habits normal, mixed diet.
Okay.
Treatment history, history of admission in de-addiction center, was on some drugs for the last 3 weeks. Details were not available.
So this is a scenario. So what all things can you make out from the history, and what are the possibilities that comes to your mind, and what will be your differential diagnosis?
Patient complains of fever and altered sensorium with the fever is a high grade, so can be meningitis, and since the patient is heavily alcoholic, then it can be hepatic encephalopathy decompensated. Then since the patient stopped the alcohol consumption 4 days back, can be again withdrawal symptoms causing this. Then patient has a past history of thyroid disease, therefore can also be a thyroid storm presenting as this fever and abdominal discomfort and altered sensorium. Then there was some consumption of drugs, the details of which is not available, but sometimes this alcohol consumption along with some drugs like the disulfiram-like reaction can cause this abdominal discomfort. And
okay, any other possibility that comes to your mind? Okay, so examination findings.
On examination, patient is drowsy, irritable, icterus is not present.
Questionable.
Then no pallor, no clubbing, no cyanosis, no lymphadenopathy, no edema. Pulse rate is 124 per minute. That's increased. That's tachycardia. Then BP is 130 over 80 millimeter mercury. It's increased. respiratory rate is 20 per minute, also increased. Then temperature is 103 degree Fahrenheit, which is very much increased. Then SpO2 is 96%. That is reduced a little bit. Normally it is about 90, more than 98. Then on CNS examination, the patient is drowsy, led by frigidity on all four limbs, moves all four limbs, plantar, bilateral flexor, reflex is normal, neck rigidity is positive, Kernix is negative. Other systems are within normal limits.
So what are the important points in the examination of this patient?
The higher mental functions, patient is irritable, and all the vitals, pulse rate increased, and temperature is very much raised. Also respiratory rate is also slightly increased. Then CNS examination, there's lead pipe rigidity all over, but the patient moves all four limbs and reflexes are normal, but neck rigidity is present.
So what's your comment about the pulse rate?
Pulse rate is having tachycardia.
So what is the usual relationship between the two? For every degree rise in temperature?
Every degree, there's 10 rise of pulse rate by 10 for every degree rise in temperature.
And what is the relation between temperature and the respiratory rate?
For every degree rise, there is rise in the respiratory rate by rise in respiratory rate by 4.
4. So those things goes with the rise in temperature. So can you enumerate some situations where you get this much elevation of temperature?
Any infective causes can cause sudden rise in temperature.
When temperature shoots to this level, what do you call that term?
High grade.
What is hyperpyrexia? So when the temperature is very high, your possibilities you must think. One is of course heat stroke, but he was not exposed to sunlight or such environments. Second possibility is he may be having thyrotoxic storm, but he's a controlled, and it's only the past week he had thyroid. Currently he is not having any thyroid disease. But there are other conditions where you can have this type of very high temperature. Again, subsequent discussion will reveal what they are. Going back to the nervous system examination, he was confused, he was drowsy, and he had lead pipe rigidity. So what are the situations where you find lead pipe rigidity?
Lead pipe rigidity is seen in extrapyramidal symptoms, Parkinsonism, then other
and then he didn't have any arrested tremor, other findings are not there, and he had neck rigidity. What's your comment about that?
Neck rigidity is positive in meningitis, then subdural hematoma, or
no.
Then
Subarachnoid hemorrhage.
Subarachnoid hemorrhage. Then
when you examine for neck rigidity, if you find that it is rigid, then immediately you must roll the neck laterally either direction to make sure the neck rigidity is not due to mental irritation but due to spasm of the muscle. So that's what is happening. So we have to be careful in committing this patient has got neck rigidity, because it goes without saying that he has got rigidity of all four limbs. So it may be the universal rigidity that is happening there. Okay, so can you summarize and tell what so far what your diagnosis will be here in this background?
Um, uh, Patient has got
So put it in the summary. He is an alcoholic. He is coming now from the de-addiction center where he was on some drugs, and then you find him in a hyperpyrexia state, and he's totally confused with the rigidity. So can you put some drugs as the culprit center point here?
drugs causing
Psychiatric drugs can produce. So your crucial
SSRI.
diagnosis, SSRI can produce what?
SSRI can produce this
You're right. What syndrome?
serotonin syndrome. Serotonin
Yes.
syndrome.
So you have some thinking here. So this particular gentleman was having acute confusional state. So what is delirium?
Delirium. Delirium is a false beliefs. In spite of providing, in spite of proving the contrary with facts.
So that is not delusion, not delirium.
Sorry, sir. Delirium.
Delirium is an acute onset of confusion.
Yes, sir.
What are the important points regarding delirium? To make a diagnosis, what all features you'll ask them?
Delirium. Patient orientation.
It will be very much fluctuating. You will find that night time they are bad, particularly bad. Morning they'll be fresh. So dawn phenomenon like. They will have impaired cognition. They will be having altered sensory. They will not understand what you are talking. And it's always reversible, fluctuating. It's not a permanent process. And it's usually a very short duration. So you suspect delirium when somebody is having sudden onset of confusion. Okay, and it will be fluctuating. Every now and then it is fluctuating. One fine woman you find is absolutely well. After 1 hour you come and see, and then he is abnormal. So this type of problem, always think about confusion. So delirium, acute confusional state is delirium when it's fluctuating with impaired cognition. Okay, so is it same as dementia?
Sir, question please.
Is it same as dementia?
No, sir. Dementia means there's progressive loss of memory.
Right. So it is progressive and irreversible. Delirium is sudden, acute, and reversible. And in dementia, the patient is fully conscious. Delirium is altered consciousness. And dementia, there is no fluctuation. And important cortical domains are affected dementia, namely memory. To start with, for recent memory, then they have problem with the speech. The third thing they get is executive functions affecting praxis, so go for apraxia, and then a problem of stereognosis. So any of these four faculties will be affected, domains will be affected in case of dementia. It's progressive as rightly said, insidious in onset, irreversible. So how will you analyze a case of delirium?
Delirium.
When you confront a patient in the casualty or outpatient, how do you look at it?
Whether it's acute in onset or not, we have to, the behavioral change.
Behavioral change must be acute. Very good. Okay.
Then if there is impaired cognitive function, then there is in between there is a normal period and
That's
fluctuations.
right. That's right.
Uh,
You also want to know what is the cause, what's the risk, what has produced the problem.
yes, right.
So you analyze them in different fashions. And a young man comes to you with acute delirium. It is usually related to alcohol,
Alcohol.
drug use or abuse, or withdrawal, or infection of the nervous system. In contrast to elderly, who is more vulnerable to develop delirium than young people. So commonly it's because of infections, maybe subtle infection about which patient never complains, like urinary tract infection, chest infection, can produce delirium. Or they may be going through different types of electrolyte disturbances. And old persons usually have multiple diseases, dyslipidemia, hypertension, diabetes, COPD, peptic ulcer disease. So he may be taking many drugs. Polypharmacy is another cause for delirium. And then of course stroke sometimes can present as acute delirium. So elderly you look from a different angle, young people you look from a different angle. Remember, in young people, infection is very important for delirium, and we should never miss diagnosis of meningitis or encephalitis. And if somebody is traveling other states, we must think about cerebral malaria. It's a treatable but potentially fatal disease if you miss the diagnosis. So how do you assess confusion? Is there any a confusion assessment method? CAM. So there's a criteria for diagnosing delirium. One, it should be acute, as you rightly said. It must be fluctuating, and he is not having normal consciousness. He's not learning anything. He has got inattention, and he has got disorganized thinking. So to make a delirium, you must have 2 points compulsorily. It must be acute, it must be fluctuating, and third or fourth point, either of it has to be present. So in the presence of 3 criteria fulfilled, 1 and 2 being compulsory, you can make diagnosis of delirium. Immediately, our job is to look at CNS. Is there any CNS organic disease that is producing delirium? Infections, strokes, any other pathology may be the culprit. Simple urinary infection, simple respiratory infection, myocardial infarction, simple pulmonary embolism, liver diseases, hepatic diseases, or treatment for psychiatric diseases can also lead on to confusion. Then you have to review all the systems. All the systems are reviewed, all this only simple confusion. One thing is, previously was this patient demented? Because demented people are one of the vulnerable groups to get frequent delirial episodes. Second is, if he is a diabetic patient, the delirium, maybe the so-called delirium may be effect of hypoglycemia or hyperglycemic non-ketotic state. If it is not epilepsy, it may be post-ictal state, what you're seeing as delirium. Nobody observed epilepsy as such, but you are seeing post-epileptic phenomenon. One group of people who are likely to suffer delirium is people who are on treatment for Parkinson's disease with dopamine-mediated drugs. A known case of malignancy, always think about metastasis producing confusional state, and retrovirus infections. They are susceptible for tuberculosis, opportunistic infections, or neoplasias of the brain. So simple confusion, a detailed history of systems is important, otherwise you are likely to miss the diagnosis. As far as a patient is concerned, the history of dementia or Parkinson's disease may not be important. They think it is unrelated, they will not reveal it unless you ask for. So also diabetes, epilepsy, malignancy. So thorough review system is essential to make diagnosis of delirium. There were so many drugs can produce problem. Particularly in the recent few days, whether somebody has added new drug or somebody has hiked the dose of the drug or somebody has withdrawn the drug or added any new drugs to the regime. Special attention to be paid to the drugs that can produce delirium, the use of opiate, tricyclic antidepressants, SSRI. What's the full form of SSRI?
Uh, Selective serotonin receptor
Inhibitors. And DOPA agonist.
dopa.
DOPA is what?
Uh, um, um,
DOP.
yes, sir.
You will memorize it, don't worry. You will come back and memorize, don't worry. Anticholinergics can also have problems of delirium. So, what this patient is alcoholic. So, what is the relation of alcohol with delirium?
Alcohol withdrawal can.
That you already mentioned, delirium tremens you mentioned.
Yes, then alcohol itself can cause vitamin B1 deficiency and wernicke's.
So, what are the other components of wernicke's?
Wernicke's encephalopathy, then
Characterized by?
Wernicke's encephalopathy is characterized by there's a loss of.
They have ophthalmoplegia. Commonly, the sixth nerve is paralyzed. They have ataxia, and they have got delirium. Okay. Can hepatic encephalopathy present like this?
Hepatic encephalopathy, yes, sir. Can present like.
So we have that must be considered in the differential diagnosis. He didn't have sixth nerve palsy. He didn't have ataxia. So that's unlikely. Delirium tremens. Delirium tremens. There was no mention of tremor, and the sequence of events were not suggestive, and he was having marked rigidity. Rigidity was the hallmark. And what are the investigations you plan?
Investigations.
Blood count, complete blood count, because you said
Yes, sir.
infection. Pointer may be there. Blood glucose, hypoglycemia, urine. There may be evidence of infection. ECG, silent myocardial infarction. ESRC-RP, again pointing to infection. LFT, pointing to liver problems. TFT, to rule out thyroid storm, as you already said. If the patient is on lithium, any drug which is known to produce problems, you have to go for drug level estimation. And hypercarbia, hypoxia can also make you delirious state. So ABG examination may be irrelevant. Tropi to diagnose acute myocardial infarction. D-dimer for pulmonary embolism, and all these investigations are not done for all the patients. Based upon the clinical relevance, you go accordingly. So, do you go for imaging?
Imaging, sometimes stroke can present as.
Yes, if you are suspecting stroke, you have to go for imaging. That's one indication. All delirious patients are not for imaging.
Then liver diseases.
Liver disease, you can do ultrasound abdomen. Okay,
Yes.
right.
Then for
So,
Then-
chest X-ray, very
Yes,
important
chest
for
X-ray.
pneumonia,
pulmonary.
infections. Ultrasound, you correctly mentioned. If you think he had a traffic accident or something like that, sign trauma, to go for a CT head. If he is a known case of carcinoma, HIV infection, or if he has paralysis, or you think there's some seizure-like activity, then think about imaging of the head. Sudden head looks like hemorrhage, you have to go for imaging. And lumbar puncture, if you're suspecting nervous system, infection. So diagnosis, you said at the beginning itself, look at the age.
Sure. Age.
Young, old. So young people, diagnosis will be
Alcohol or infections.
drug use or abuse,
Yes.
HIV infection. Elderly,
Simple infections.
infection
Then
is right. Second one,
then
polypharmacy comes third.
polypharmacy, stroke, then hypertension,
Fecal impaction, urinary retention. Subdural hematoma, never forgot. But in between, they say people know, or there are common things pertain to all people. So that is applicable to all ages. Need not be very old, need not be very young. So this is not a very strict classification. So who are all likely to suffer with delirium?
I said alcoholics, then generation.
Elderly,
Yes, elderly.
Parkinson's disease.
Okay, sir.
Then
Then
so already
patient with
who are
chronic
demented,
infections.
already who are demented and who has got difficulty to see or hear, post-surgery situations, alcoholics, drugs. So old people, when they are admitted to hospital, suddenly they become delirious, especially the peri-operative period. And dementia people very frequently become delirious. Slightest of infection, they go delirious or delirium on dementia. Third category, Parkinson's. Very frequently they become delirious. Okay, so check always the drug list of these patients. Polypharmacy can be one cause, and dependence on alcohol and drugs is another important cause for predisposition. Now, how will you treat these patients?
Treatment.
Simple delirium. Treat the cause. That's policy. Treat the cause. Okay, infection, pneumonia, meningitis, cerebral malaria. Treat the cause. What's the cause? Electrical disturbance, infection. You treat it accordingly and give them electrolytes and fluid so that you support them in adequate calories. If there's fever, cool down, temperature must come down. Then, for timing, you have to settle the patient by using haloperidol. Okay, or you can short acting Davenso diazepines. If it's a suspected liver disease, lower will be better option than others. So, what is the diagnosis in this case?
Diagnosis. She
Go back. There's one more investigation just done in this patient was CPK, which was around 5,000. So we were saying that this patient is coming from a center where there was de-addiction was going on. He was on some drugs which we did not know. When people come back with hyperpyrexia from such situation, our differential diagnosis is going. That's why I asked at the beginning itself whether you think about any drugs, neuroleptic malignant syndrome, and you correctly pointed out serotonin syndrome as possibly. Right. So, what is neuroleptic malignant syndrome?
Seeing patients in drugs for
potential life-threatening emergency. Seen in patients who have been recently started on neuroleptic drugs, either dose increased or decreased, some alteration, and patients in whom a dopaminergic agent has been recently withdrawn. First started with the haloperidol. Usually there's a latent period of 7 days after starting the treatment, unlike serotonin syndrome, which starts within 1 or 2 days time. This gap between the onset of the disease is very important. So, what's the pathophysiology?
Decreased dopamine activity in CNS.
So we said there's a couple of drugs. They are all acting through dopamine.
Dopamine.
So they block the dopamine 2 receptor,
Dopamine.
and dopamine is not available as it should be. So the pathways of dopamine. What are the pathways of dopamine?
Uh, Substantial
The
Nigostyle pathway.
so extrapyramidal, mesolimbic, and
Mesolimbic.
hypothalamic pathways will be in trouble. So in summary, when you withdraw these drugs, suddenly you have problem of dopamine. So the central dopamine dopa blockade, extreme left part of the column, you see it is acting through areas. One is hypothalamus, and hypothalamus is involved in your temperature regulation. That's why these patients are going for hyperthermia, and it's also involved with the autonomic disturbances. So the patients have got autonomic disturbances producing all autonomic manifestations like arrhythmia. Sometimes blood pressure will be very high, sometimes it be very low, and respiration may also be irregular. And when it affects the extrapyramidal, as you rightly pointed out, it produces rigidity, as you have seen in this patient. Okay, neuroleptic withdrawal of L-DOPA or similar scenarios can also affect your peripheral muscles directly. Again, same thing happens, rigidity occur. Here also find the muscles undergo lysis, rhabdomyolysis, and that's the reason for what? Raised CPK.
Yes, sir.
And sympathetic hyperactivity again manifests as tachycardia and elevated BP. So, what are the signs you get? Hyperthermia,
Rigidity, hyperthermia,
altered mental status, autonomic
instability,
and
elevated CPK.
So all these signs can be explained based upon the previous diagram where the sequence of events are shown. So the message here is, when somebody is coming with fever or altered sensorium, as usual we go for the review system. If we get some clue regarding the diagnosis, proper drug history must be documented. Not only the name of the drugs, when it was started, when it was increased, when it was withdrawn. That may give a clue to your diagnosis. And then there are criteria for diagnosing neuroleptic malignant syndrome. This patient got fever, rigidity, elevated creatine phosphokinase concentration, but he also has got tachycardia, okay, altered consciousness. So both criteria are satisfied. Major and minor are available in this particular patient. Who are all the people who are likely to suffer with neuroleptic malignant syndrome?
Patient who was on Parkinson's.
Yes. So dehydration, agitated people, organic brain disease, young people who has got trauma, infection, malnutrition. This background is more likely to create problem. Alcohol. Then of course, drug dosing factors. And dose of the neuroleptic sometimes given is very high, especially in de-addiction centers. Haloperidol. Okay. Or somebody may be hiking the dose very fast. Or you depot neuroleptics. Whatever it be, these people are likely to get neuroleptic malignant syndrome. It should be diagnosed. It should not be missed. That's the point. So there's a couple of pointers that there, very high fever, tachycardia, labile blood pressure, altered sensorium, delirium, rigidity. Never forget rigidity. And then you just do one investigation, CPK. Of course, white cell count may be high, other parameters there. So many drugs are said to be the culprits, but commonly used one are they like this. Okay. So when is the entacapone used?
Entacapone.
End of Parkinson's disease. Okay. So wide varieties of drugs used the treatment of psychiatric diseases are given, and some of the other drugs are also involved. So what will be differential diagnosis in this case? You have to look at differential diagnosis diagnosis from his symptoms and signs. His symptom is one, altered sensorium. Symptom number
altered sensor,
fever. And signs are
rigidity,
tachycardia, hyperpyrexia, rigidity. Accordingly, and the background story is on from de-addiction center. And we have got a clue that his CPK is very high. So, what all differential diagnosis can arrive at?
Delirium tremens.
Delirium tremens is possible, but rigidity is not in favor. CPK is also not favorable.
Then
his liver function test is normal. So although he is an alcoholic, there is nothing to suggest that he has got cirrhosis liver.
Then
he doesn't have goiter. His thyroid function is normal. And currently he is not having thyroid disease. So thyroid storm is unlikely. So can this be serotonin syndrome?
Yes, can be. But onset is
will be soon after starting.
Soon after.
Not okay. And serotonin syndrome basically is very aggressive people who will be moving around. Movements, they are not just taking rest. Lot of tremor, lot of clonus, very active. Unlike the silent person of neuroleptic malignant syndrome, where the patient is just bedbound in a delirious state. What about malignant hyperthermia?
Yes, it can.
Where does it occur? What scenario?
Malignant hyperthermia occurs in thyroid.
It commonly occurs when people undergo anesthesia in an operation theatre. It will also be characterized by high fever and delirium, but then the background story will be very clear to you. Nervous system infections, there will be appropriate clue and you can do lumbar puncture or other investigation. Heat stroke has got its own background story, so also delirium tremens. Parkinson's disease history and findings will be supportive. And if there are seizures, all diseases in this category will be having their own specific symptoms and signs. The closest differential diagnosis will be between serotonin syndrome, malignant hyperthermia,
and
delirium tremens, thyroid crisis. So there will be the closest differential diagnosis for this particular patient. So serotonin syndrome is a situation where side effect of a drug, where serotonin agonist is involved. Here we have dopamine agonist. So the two different types of drugs. The onset is within hours after starting serotonin syndrome. Here it will take days and weeks. And the course of the disease again very, very fast. Except in flu activity. And here it is, course is days to weeks time. And the findings of serotonin syndrome are mainly myoclonus, spontaneous clonus, tremor, hyperreflexia. Here you have rigidity and bradykinesia. So neuroleptic malignant syndrome is bradykinesia. Other one is mainly increased movement. Hyperkinetic state, serotonin syndrome. Pupils are commonly dilated in serotonin syndrome, it is normal. And nausea, vomiting, diarrhea are usual in serotonin syndrome, not here. The closest differential diagnosis. So how will you treat this patient?
Dopamine agonist.
Commonly, hyperpyrexia is not good to the body. As the temperature goes up, it destroys all your systems. So you have to cool down the patient immediately. Okay. And any side effect of any drug, first step is withdraw the drug, no more doses. And they are very much agitated. You have to sedate them, but usually they are very much dehydrated. Hyperpyrexia itself can produce dehydration. So make sure they get adequate amount of fluid. Lot of IV fluids are given and urine is alkalinized with IV sodium bicarbonate to prevent rhabdomyolysis. Myolysis. Cooling blankets are available, or you can ice packs can be kept. You give them electrolytes, renal functions and blood pressure should be maintained, and you can give lorazepam or clonazepam. Dandrolene can also be given. Bromocriptine can be given. Amantadine, levodopa, carbidopa, ivaclonidine, and benzodiazepine. So commonly dandrolene or bromocriptine are given. Drugs of choice. And prognosis, they resolve within 2 weeks. Unlike in case of serotonin syndrome, where rapid recovery takes place. Recovery within 2 weeks time only. And some of the patients may have residual catatonia lasting for few months time. Mortality is very low, provided you detect it on time and treat the patient. So message of this case is, all fevers are not infections. All delirium patients are not having functional disease. There can be part of organic disease. So also this case teaches you that delirium is different from dementia. Delirium is acute, dementia is chronic. Delirium is reversible, dementia is progressive. Delirium has got fluctuation, dementia has no fluctuation. So this difference, delirium and dementia, must be differentiated, and delirium has got many causes. To find out the cause, you have to be very broad-minded, and history taking must include symptoms pertaining to each and every system, so that you can make a professional diagnosis. So proper history taking is the clue to make the diagnosis here. So couple of questions. Emil was telling repeatedly that stroke can present as delirium. Which stroke present as delirium?
Sir,
Which stroke presents as delirium? Delirium can be presentation of non-dominant parietal lobe, temporal lobe, and occipital lobe.
okay, sir.
Of strokes can present as abnormal behavior in a person. What are the features of delirium tremens? It's already mentioned. How do you diagnose thyrotoxic crisis?
There will be increase in temperature.
Right. And all the features of thyrotoxic crisis, hyperpyrexia, and delirious state. And commonly,
Yes.
some procedure is done, like surgery, on a patient who is not under treatment for thyrotoxicosis, or you have gone procedure like uptake study or biopsy are usually candidates. And what is the cause of delirium in organophosphorus poisoning?
There will be CNS effects will be there, the anxiety, restlessness, ataxia will be there, tremors will be there.
But the question is, what are the causes of delirium in OP poisoning?
Muscarinic effects will be there.
OP poisoning usually produces, we are treating with atropine. So one possibility is a atropine side effect. Second possibility is the patient has got problem of the poison itself. Third is the patient has got retention of urine.
Yes, sir.
Nothing can make the patient restless. So atropine is one important cause for delirium in medical wards. So back to serotonin syndrome. What are the three components or triad of serotonin syndrome?
There can be hyperactivity.
One is hyperactivity. Yes, autonomic hyperactivity.
There can be neuromuscular hyperactivity.
Neuromuscular hyperactivity, number 2. And mental changes. Mental changes. Okay. And how do you treat serotonin syndrome? Do you have any serotonin antagonist?
So we can give supportive treatment. Start with supportive treatments.
Specific treatment is a drug called cyproheptadine. It's a serotonin antagonist. Why do people get serotonin syndrome? What's the background story? Because of drugs acting through serotonin is used like fluoxetine for therapeutic purposes, or there was some interaction between drugs. Very rarely, it can be an overdose by a patient. Self-poisoning can also produce the problem.
Okay, sir.
Serotonin normally present in the human body.
Yes, sir.
Where all it is present? It is present in what regulation in the central nervous system.
Okay, sir.
And peripherally, it can produce vasodilatation, it can produce bronchoconstriction. So situations like carcinoid syndrome, where a lot of serotonin comes in, you get bronchospasm, and you got peripheral vasodilatation, producing flushing.
Okay.
Increases the gastrointestinal motility, producing diarrhea in those patients. And in the platelet, increases the aggregation. Okay, so cyproheptadine. What are the other use of cyproheptadine? We already mentioned the criteria for neuroleptic malignant syndrome. Are there any criteria for serotonin syndrome? Serotonin syndrome is commonly diagnosed when the history of intake of a drug, SSRI, or some other drug is present. That is compulsory. Plus spontaneous clonus of different parts of the body, or you get inducible clonus, or you get observed clonus, ocular clonus, or you get tremor with hyperpyrexia, or you get hypertonia. In those scenarios, you can diagnose serotonin syndrome.
Okay.